Hello, we're going to do a little flipped classroom learning trial for this section of Kisner-Colby. This first lecture is about range of motion from chapter 3 of the textbook, and then there'll be another lecture that's posted related to chapter 4 and a little bit of chapter 10. So in your textbook there's a number of chapters, but we want to think about the interventions or possible categories of treatments that we'll give in three main sections. So there's some range of motion exercises, there's flexibility or stretching, we're going to cover that today. There's aerobic exercise or cardiorespiratory endurance, and we will address that. You'll also get more in your cardiopulmonary and vascular class next fall. And then there's muscle endurance exercise and strengthening, which is really a quite large category of interventions that we do. And the piece that's missing here is the modalities, because they really are to help support or provide some different physiologic benefits as we then engage in these different therapeutic interventions. What is range of motion? So in your book it's defined as the amount of motion between any two articulating bones. That's our goniometric measure, which we started talking about yesterday. And you have to realize that we also have mobility or range of motion of muscle, tendon structures. We also have motion or flexibility in ligamentous tissues. So what determines the amount of motion is really the structure of the joint. So that's where your convex, concave information or relationship comes in, and also the health of the joint. What's the tissue integrity around the joint? The capsular ligamentous structures, the ligaments that are part of that capsule or separate from, and then the other tissues that cross that joint, so ligaments or tendons that might have an impact. An example of this is active or passive insufficiency. So if you put your arm out straight, and I want you to do it with me, and then keep your arm straight and flex your wrist, and then try to grip with your fist. So your arm is straight, palm is down, wrist is flexed, and then grip with your fist and feel how that feels. And then repeat that, but bring your elbow back to your side so your elbow's bent to 90 degrees. Your wrist is flexed, then try to make a grip. And what you should notice is one of those situations it was a little easier to make a firm grip, and that should be with your elbow by your side. So why is it harder when your arm is outstretched and your wrist is flexed and you're trying to make a fist? Well, there's some passive insufficiency of your wrist and finger extensors, limiting the ability of your wrist and finger flexors to work. So that's the terms for that, or that's an example of passive insufficiency that would limit your motion. You need to be mindful of that when you're looking at true joint range of motion, that you're making sure all those tissues around the joint are not causing a limitation of actually being able to move or measure what you want. So some norms for range of motion you were given in exam and eval. Realize again that there's much interpersonal variance, and so you need to assess the ability of each person. Even though you have to know the norms, it's a starting place, and then as you practice you'll begin to have a better sense of what's really functional, or is this really a problem I need to deal with. We have three types of range of motion exercises. We have passive range of motion, where someone does it for the patient, or something does it for the patient. We have active assistive range of motion, where there's help with the patient doing some, and the either mechanical device or an external force does it. So, and then there's active range of motion, where the patient does it all by themselves. When should you not do range of motion? So if motion's going to disrupt the healing process, in the acute stage, following a tear, a strain or a sprain, grade 3, surgery after fractures, so the big stuff, most often we can do range of motion. Okay. If range of motion causes more pain or increases inflammation, that would also be a contraindication. So this is a situation in the image here where you see bone growth in the muscle. This is called heterotopic ossification, and it usually happens when there's been a contusion to the muscle and then there was vigorous stretching or activation of the muscle. So that would be a contusion, might be a contraindication to doing range of motion even to a muscle if there's a likelihood that this heterotopic ossification can form. What are the indications for range of motion? So we want to do passive motion when we have that acute situation. If active movement's not possible, or it's contraindicated. So maybe the patient has a nerve problem and they have no muscle function, then passive range of motion is going to be indicated in that situation. When am I going to do active assistive or active range of motion? When normal activity is limited, but I need to have range of motion. If there's muscle weakness and I'm not able to get the range, then it's good to be doing range of motion exercises. You can do range of motion for aerobic conditioning. Now that patient is probably they probably have multiple medical things going on if range of motion becomes an aerobic training program, but it can be that case. And if there's some venous stasis, range of motion helps. The ankle pumps is an exercise post-surgery is a classic example of that. So what does range of motion do? Passive range of motion maintains tissue flexibility, circulation, movement awareness, and cartilage nutrition. It also inhibits pain. Active range of motion does the same. It inhibits pain. It also can increase tissue flexibility, circulation, and cartilage, bone, and muscle nutrition. Because we're using the muscle cell, we get a little bit better stress strain on the collagen fibers within the muscle. There's also some neuromuscular input because, again, we're activating the muscle, so we can actually prevent some muscle atrophy, whereas that's not the case with passive range of motion. It does not prevent atrophy, it does not increase strength or endurance, and it isn't as good at helping with circulation. On the other hand, active range of motion does not increase strength if the muscle is already at a grade 3 or better. A grade 3 muscle is a muscle that can lift the body part or the limb fully against gravity. So that would be a patient who is not able to move against gravity. Then active range of motion will increase strength. If it's already able to move against gravity, active range of motion does not increase strength. And active range of motion does not develop skill or coordination. It's really not a functional tool. It's more for that nutritional benefit. When I do range of motion, I need to have certain parameters or I need a prescription. So first off, is there an indication? That's true of any therapeutic intervention. What's my indication? So do I need nutrition to the tissue? Do I need to inhibit pain? Is there a need for keeping flexibility in the tissues? And then I need to determine where I need to do the intervention, what joint or muscle, what technique I'm going to use. So am I going to do active, active assistive, or passive? What's my pattern of movement? What am I doing? What is the patient doing? What position are we in? And then the dose, how much? So the FIT model says frequency, intensity, time, and type. So here we're doing reps, sets, frequency, because we already put the type up here. So I have a case for you to solve. Mr. Joe is a 27-year-old man. He's been diagnosed with an acute TBI or traumatic brain injury. He's in a medically induced coma because he had some surgery to relieve pressure, so he has what's called a ventriculostomy, or it's a drainage tube. That means the head of the bed needs to remain elevated at 30 degrees. He doesn't have any volitional movement. He has flaccid muscle tone. He doesn't have any loss of motion when it's tested passively, so his examination doesn't indicate a loss of motion. And my question to you is there an indication to do range of motion exercises with Joe? And if so, what would those parameters look like? So pause the video and work through this list of indication, which joint, what type, how much, and see if you and I agree. So already you know it is indicated. So if we talk about Joe's indications, we want to prevent stiffness in key joints. So how do we identify key joints? This is where you need to think functionally. We don't really know much about Joe and what his lifestyle factors are. We don't know if he's working or not working. We have no information related to the type of job or activities he does. So we need to think just globally. What are the typical things a patient needs to do? They need to be able to feed themselves, take a shower, wash their hair, perhaps get up and down from a chair, lay in bed, get up from the bed, hopefully walk, And so the motions or the joints involved in that would be shoulder elevation with elbow extension, hip flexion and extension, knee flexion, knee extension, and ankle dorsiflexion. So because he has no volitional motion, we're going to start with passive range of motion, and then we may move to active assistive motion once that medically induced coma is gone. To do range of motion and maintain muscle length, I only need to do 1 repetition per day. However, to improve nutrition to the structures, I'm going to suggest 10 repetitions of each motion would be beneficial. I'll do 1 set of 10 repetitions, and because I don't need to do it every day if I'm doing it this frequently, I could decrease that to 2 to 3 times a week. Likely you're going to teach someone else how to do passive range of motion, so that will be a skill you'll do during lab because you'll be instructing others on how to do it. You should be familiar with it. So let's talk about Tom, a 28-year-old male science teacher and recreational softball player who's 1 week status post SP left rotator cuff repair. He's in a sling, so he has to keep that on until he's 2 weeks post, and he has restrictions, and this comes from the physician: no external rotation beyond 40 degrees and no active movement until 4 weeks after the operation. So again, are there range of motion indications and parameters? Yes. So again, pause the video and work through what you would do with Tom, which motions you would address, and how much of that you would do. All right, let's see how well we did. So what type of range of motion? Well, all motions of the shoulder would be important, but the position that we put our patient in may limit some of our ability to get shoulder extension. Typically, a patient's going to lie supine, and so being able to do flexion and abduction, external and internal rotation, and perhaps some horizontal adduction or reaching across to the other shoulder would be possible. We're going to do all of this passively. That means Tom's going to be coming into the clinic for us to do that. We'll probably have him come in 2 times a week or so. We might also be teaching him some passive movement he can do at home so that he doesn't have to come into the clinic every day. It really matters what your patient's and surgeon preference is. I'm going to do 1 to 5 repetitions and just 1 set of that. I'll follow up with some range of motion instruction for home that he should be doing 3 times daily. What's going to change at 3 weeks? How would your exercise program change? So at 3 weeks, he has the ability to be out of the sling, but those restrictions of external rotation to no more than 40 degrees and no active range of motion remain. So this is a time where you can begin to do what we consider or call passive range of motion, but really anytime you grip something in the hand, the shoulder is engaged. So things like pulley exercise or cane or wand exercise, they're called, could be instructed, but we have to appreciate that there is some activation of the rotator cuff, and so guiding the patient at this point would be very important for quality of movement and giving some education about self-care and signs and symptoms to watch for of overwork. The other piece that you need to consider is what's happening at the shoulder girdle. So is Tom at swan, keeping his scapula nicely depressed and retracted when he tries to elevate, or is he being a turtle because he has the habit of letting the shoulder girdle, the scapula, elevate? Some typical activities are pulleys. You can see down here. It's set up so that when this gal does flexion, it's going to pull her more into midline. Sometimes these are done standing, or you can also sit facing away from the door. The wand exercises are very common, so you have flexion that's done here. This is showing doing external and internal rotation with a supinated grip. This is showing extension. Now these are active movements unless you really can educate Tom to not allow the surgical shoulder to move and let the other arm do this. as Tom moves along in the timeline from 1 week out to 3 weeks out, we should be doing still that 5 to 10 repetitions, but you're doing it frequently to prevent range of motion, prevent stiffness, and to increase nutrition in the cartilage. Now note, we're doing range of motion. So very often we confuse range of motion and stretching. Does Tom likely need to gain motion? Absolutely. He's post-op, he's got muscle guarding, and there's pain. But we're talking just strictly range of motion to enhance nutrition. You may ask him to move into the limitation, which is then stretching, and hold it there so you can combine the two. But for this purpose, I really want you to distinguish the difference between range of motion and stretching. We also have some mechanical devices that can help us move joints, and they're called continuous passive motion machines. They have the same benefit as for passive range of motion. The risks is that you could have increased pain medication use, and that's mostly because they're put on improperly. They're also moving the joint a lot. There's also a chance that there's some increased bleeding or drainage from the joint, although things have gotten better and that may not be as much of a concern. There's different devices for the different joints. Research studies show that there is some benefit short term. However, at 4 weeks out, the results are pretty much the same, and the cost is fairly prohibitive, so you may or may not see those. We do have a knee CPM, and you'll be exposed to that, and I know one of you luckily draw that piece of modality, so you're doing your instruction sheet on that. So what are some general guidelines? This is a shoulder CPM. You can see how the harness is hooked here. Looks like they're working on range of motion. You can, with this, adjust which plane of motion you're doing. So it may push them up and elevate. It may just stick here and do external internal rotation. You can swing the arm out also and do external and internal rotation in more of an abducted position than in a flexed position. So when you align a CPM or put it on, you need to make sure that the mechanical axis of the CPM aligns with the joint axis. If you don't do that, that's where pain happens. And then the settings should be noted so that you're working in the range of motion that the patient has available. If you're stretching, then you need to note that. So the suggestion is that you might start for a knee CPM of an arc of 20 to 60 degrees of knee flexion and increase 10 to 15 degrees per day. The rate at how fast that the machine cycles would be a very slow rate so that there's not muscle guarding or cramping. So 45 to 120 seconds might be the time it takes for the machine to pull into flexion and the machine to pull out into extension. For shoulder, if you're doing something like elevation, it might take even longer to do that. You might use this for 4 to 8 hours a day, so often a patient will sleep in a device. For a shoulder CPM, I doubt they're sleeping in the chair, having their arm go. So you might do 2 hours 2 or 3 times a day because they're fairly much stuck in the chair when they're doing that. All right, so I hope you've enjoyed this flipped learning about range of motion, and stay tuned for stretching.